respected chairpersons, dear delegates, we are coming to the end of our scientific program. This is the last speaker of our Rehabcon 2025. I will give an overview on shoulder disability. My presentation includes ability, disability and assessment of disability of the shoulder. You don't know? Ability. The shoulder is the only joint having 180 degrees of movement in flexion, extension, adduction, abduction and rotation. So on the other hand, this will definitely compromise stability and which can lead to disability. Shoulder acts as a platform for hand functions. If the range of movement of the shoulder is affected, definitely that will affect the function of the hand also. Even the hand is fully functional, we cannot fully utilize the hand function. Disability results from the interaction between an individual's health condition, environmental and personal factors, potentially hindering their full and effective participation in society. Disability is the experience of any condition that makes it more difficult for a person to do certain activities or have equitable access within a given society. Disabilities may be cognitive, developmental, intellectual, mental, physical, sensory, or a combination of multiple factors. As far as physiatrists are concerned, locomotor disability is very much important. Locomotor disability means a person's inability to execute distinctive activities associated with the movement of self and objects resulting from affliction of musculoskeletal, nervous system or both. Disability of shoulder results from the loss of range of movement of shoulder, loss of strength or coordinated activities around the joint. So, when the range of movement or strength or the coordinated activities around the shoulder is affected, then they can lead to disability. Then coming to the assessment of disability. For the assessment of disability, it includes, we are very much aware of it, then it is only a repetition. The maximum disability to upper limb is 100%. The whole body disability is also disability. So the maximum disability a person can get is 100%. For the ease of assessment of disability of upper limb, it can be divided into arm component and hand component. Together 90% and 10% additional weightage. The arm component, maximum value of arm component is 90%. It includes three factors, that is loss of ROM assessed out of 90%, loss of strength assessed out of 90%, loss of coordinated activities assessed out of 90%. Each condition out of 90%. These three, this loss of ROM, loss of strength and loss of coordinated activities should be combined using the combining formula A plus B into 90 minus A divided by 90. So these three values added together, we will get disability of the arm component. Then hand component, the maximum value is 90%. It includes the loss of prehension, loss of sensation and loss of strength. Then loss of prehension, maximum value is 30%, loss of sensation 30%, loss of strength again 30%. Because this loss of prehension, loss of sensation and loss of strength are assessed out of 30%, we should add directly, not using the formula. So added directly, we will get a hand component. This is hand component out of 90%. Now we should combine arm component and hand component. Again, by using the telescopic formula A plus B into 90 minus A divided by 90, we will get upper limb disability out of 90%. Then the 10% is the extra point. There is additional points. Then this already told, This arm component, it includes loss of ROM, loss of strength, loss of coordinated activities, loss of ROM, this shoulder, elbow and wrist, maximum values 10%, 20, 20, 20, 20, 20, 10. Sorry. And again, the 40% loss of ROM is given to the hand component, hand ROM restriction. We have, even though it is included in the arm component, don't forget to remember that this 40% to the hand ROM restriction. So 20% disability due to restriction of shoulder, 20% to the elbow, 10% to the wrist, and 40% to again to the hand restriction. So together we will get 90%. Then loss of strength, it is easy. Shoulder, elbow and wrist 30, 30, 30. So together we will get 90%. Then loss of coordinated activities, we have to check for 10 things. For each item we can give a maximum of the 9%. We are now using the revised guideline, that is a 2024 revised guideline released on March. Earlier it was for each component 9 items are assessed. Now each component maximum value is 9, 10 components are there. Okay. This is for coordinated activities. Again, the 2018 guideline, it was written as maximum value is 10% for each. Here there is a change. They are again subdivided into if no limitation 0%, mildly impaired 3%, moderately impaired 5%, severely impaired 7%, totally impaired 9%. Some more clarity is there. In loss of coordinated activities, we are assessing lifting overhead objects, removing and placing at the same place, touching tip of the nose with the tip of a finger, then eating by oneself, grooming, putting on a shirt, activity of ablution, drinking water, holding a glass, buttoning, putting on trouser, holding a pen or pencil. These are the 10 items. Then again, hand component, there are 3 components. There is a loss of prehension, loss of sensation and a loss of strength. There is a 30, 30, 30. We should add together directly. We will get this hand component. Then coming to the additional weightage. What are this is for 10%, rest 10%. This if the affected upper limb is a dominant hand, this is acquired disability. This is for only acquired disability. If it is a congenital, this is not applicable. Coming to the deformity, if it is in the functional position, we can give it 3% only. If it is in non-functional position, 6%. Pain, if it is a mild, moderate, severe, 3, 6, 9%. So maximum 9%. Loss of sensation, again we can give for partial 6%. Full loss of sensation, we can give 9%. Again complication, superficial or deep. Superficial 3%, deep again 6%. The shortening for first 1 inch, there is no disability. After that, for each 1 inch shortening, 2%. Please note that there is no limitation for shortening. We can, if the disability due to shortening is the 20%, we can give. This is a combined formula. Disability percentage is to be stated in relation to the extremity that which can be used in India for the past many years, in the absence of a generally agreed upon system in India of reflecting in relation with the whole body. Disability should not exceed 100%. Disability should be expressed in the whole number only. Should be, നമ്മൾ പലപ്പോഴും സർട്ടിഫിക്കറ്റ് വരുമ്പോൾ അതിൽ ഫ്രാക്ഷൻ വരുന്നുണ്ട്. നെവർ ഗിവ് ഫ്രാക്ഷൻ, ഷുഡ് ബി എ ഹോൾ നമ്പർ. താങ്ക് യു.
invite all the speakers of this session to the dais for an open discussion.
But the thing is, I think ergonomics and shoulder, the topic is incomplete. Because ergonomics and shoulder together will not go. It should have been combined with the spine, cervical spine, lumbocervical spine, like that. So the topic itself is incomplete ergonomics wise. Because if you select a regime of any fitness regime, any dynamic stretch, shoulder alone should never go, because it should be always, all regimes are spine combined. So any ADL, if you involve in any house called ADL also, it is combined. That is what Selvan was saying. It is all combined with core. So suppose if you have a shoulder strength alone of grade 5, it won't do much. So shoulder strength along with the spine, the whole spine, especially the core with the abdomen, will go together. So maybe Selvan, if you gave the topic, but the next topic should be ergonomics, only ergonomics. Maybe the body ergonomics, the shoulder and ergonomics, which is very nice. Why during introduction, Selvan was saying he took 3 minutes to explain why I was just holding back to take the topic, because it's very difficult to talk on ergonomics and shoulder alone. So anyway, it is good because since I am much involved in most of dynamic stretches, because it is dynamic works well rather than a static stretch. So you can stretch each and every muscle statically. That is why our Prime Minister Modi is having a body language of just like a king. That person was saying, like that Brittas was saying, he presents like a king and he enters like a king in parliament, because he is much involved in maybe 45 or 1 hour of yoga. Yoga is a dynamic stretch. So yoga is good, because if you say yoga is good for health, that has to be complete. It is again incomplete, because yoga is good for health provided. So the sentence should be completed. The thing is, the dynamic stretch will go a long way rather than static stretch. That dynamic stretch involves, if you aim at stretch of a shoulder, it aims at shoulder and spine. And core with shoulder will go together in dynamic. So you can't stretch shoulder alone. That is possible only statically. So the topic is, the next conference topic will be ergonomics combined. Thank you, very nice. And again, one more, Hariyan sir used to say in my earlier times, in 2004 when I joined KIMS, Hariyan sir used to say, you should not walk like this, you should walk this way. That was again, Selvan was saying, this is the way. So shoulder retraction, the elevation retraction is a very good stretch and exercise. It should be retracted this way. So I always used to say, you should always walk this style, don't walk this way. Because protraction will always alter a bad posture. And one more thing is that during gym activities, my madam in anatomy in Govt Medical Rehabcon is a power lifter. Dr. Indira, aged around 55 years, she is a power lifter, is the HOD of anatomy in Govt Medical Rehabcon. And during discussion fitness WhatsApp group, we have got a doctors group led by neurologist of Kottayam, Jacob Joshar. So there is always a lot of discussions going on in the group. And in one of the discussions I was saying about Madam's posture. Madam is a power lifter, but posturally Madam's posture is very bad. So even though she is a power lifter, she walks like this. So that doesn't seem that is a power lifter. So I was just telling that, Madam, your posture is so bad. Is there anything wrong with it? So posture is, that you get a good posture is very difficult. So you should come mainly from gradual static plus dynamic stretches regularly and should be continued. So that means that if you are a power lifter also has got a bad posture. So suppose if you go to gym, that doesn't guarantee that you'll get a good posture. That is why many a patient come with all sort of pain after going to gym. So it is a extended, enhanced stretch will give more of a health.
May I speak? I'm very happy that Dr. Shweta talked about the importance of teaching the patient retraction of the shoulder, which has been a very important point in preventing shoulder pain, a very common cause being bicipital tendonitis. So I always tell my PGs to teach the shoulder retraction exercises. Most patients come with this type of stooped posture, and they have shoulder pain also. So I'm very happy, Shaida, that you brought this up out of the blue, and I was just thinking about it all the time when you brought it out. The second thing is about pelvic tilt exercises in sitting position, that the exercise has to be taught very properly. Otherwise, the patients, they will left to themselves, they will start pushing out and they will end up with more back pain and hernia. So the pelvic tilt exercises has to be taught by an experienced person or by the physiatrist himself, because otherwise they will do it the wrong way, the pelvic tilt exercise. Thank you.
Sort of bigger. And I have a doubt for Dr. Selvan. You are saying that this the additional percentage for shortening, 2% for every inch. Suppose somebody has got 7 inches shortening. Will you give 10% or 14%?
Sorry, shortening there is no limit.
But additional percentage is only 10%. So can it exceed?
Yeah, sorry, it is specifically written in the this guideline, that is except shortening, that is in the upper limb and lower limb, except shortening we can give a additional point up to maximum 10%. Shortening, it is not limited to 10%. Actual for a first 1 inch there is there is no disability. After that, for each inch there is a 2%. So if it is a 7-inch shortening, we can give 14% as added.
No, thank you. Because I am not issuing this disability certificate for many years now.
Okay.
So I am not aware of these things.
This is actually in the guidelines.
How will you take that 40%?
Yeah, it is for
14 joints, I think.
yeah, again in the annexure there is a clearly stated that how it can be assessed for. There are, I think, 49 joints or something. I am not remembering. It is if you want to clearly measure the loss of RM, you have to measure the RM of each joint. When another way you can give that there is the RM restriction of hand is mild, moderate or severe. If it is mild, this one third of 40%, moderate 2/3, or if it is fully affected, we can give 40%. So it is easy that. Otherwise, you have to measure the hand joints each RM.
What I do as a solution is divide the fingers divided by 40, and then give more weightage for the thumb, and then you fractionate it. So that's an easier method. It's not exactly given as, because you know that guidelines cannot be made perfect.
Dr. Vinita. Element shoulder conditions, there are umpteen number of conditions, and number of conditions starting from traumatic nerve injuries, nerve compressions, and you mainly concentrated on neurological and congenital diseases due to, it's due to time shortage. But there are lots of conditions, and it should be clearly differentiated from the conditions like rotator cuff injuries and arthritis, which mimics like an 11 condition. It's important in the treatment part also.
So actually, yesterday there was a whole talk on brachial plexus, so it saved my time. That's why I didn't add all those nerves into my presentation.
At Trivandrum, we are also part of the SMA clinic, and we have seen more than, over the time, we have seen more than 100 separate children regarding shoulder weakness and upper limb. So interestingly, that we have found that even though certain children are weak, if we lift our hand like this, SMA children with their weakness, with their intelligence, they have found ways to actually lift the hand up to the shoulder. This is what we have seen. We need to study on it to find out whether these patterns can help children lift their hand and do better function. So just a notice, our postgraduates have seen those children.
Selvan, about this, anybody from the audience also, about this disability, I think that this is a very complex procedure. And I think now the NMCA is coming out with the simplified guidelines just to how to perform the activities of daily living. Anybody, I don't know whether anybody is aware of that.
Sorry, regarding disability assessment, still now the active guideline existing is revised disability assessment guideline 2020. No further updations.
Sure, sir. Do we have any guidelines regarding the use of smartphones? Because most of us are getting a lot of cases regarding due to the smartphone.
I have not looked for any guidelines. There may be some guidelines, but these are the basic principles. I think you do not need guideline. If you have this basic understanding of biomechanics, and anyway you do not call something as a hunting pain or a walking pain or reading pain, do not relate some equipment to the pain. The pain actually comes from the problem with your body posture. It's better to try to correct it that way.
Just to help with ergonomics, you see it from the point of view of participation. See you ask the patient what the patient cannot do, and use the ICF to divide the problem into impairment, activity and participation, and the environment also. We usually do not ask about the environment. So you ask if the lady cannot do cooking, then you see at which level, you ask her at which level she's keeping the vessels, and then modify the environment little bit in a way that is possible at their house. Rather than just prescribing change the whole kitchen, you just find small solutions that can be, and you can ask them also to find the solution, and that I would say is a better principle of identifying ergonomic issues.
I always think that this disability evaluation, some modification has to be there, because most of the time we are assessing the impairment, not the disability or handicap. Because actually what we need is assessment of the disability or the functional loss to the individual. For example, I will tell you one thing. A patient who is a below-knee amputee, who is using a modern process with a very good ambulation, and another patient again with a below-knee amputation but not able to walk because of certain other complications. Both of these patients will be getting the same percentage. Is it a correct assessment?
Sir, regarding this, sir, സാർ ചോദിക്കുന്നതെന്ന് പറഞ്ഞാൽ നമുക്കിപ്പോൾ ആളെന്തായാലും കാലില്ല സാർ. അപ്പോൾ കാലില്ലാത്തതിൻ്റെ അസസ്മെൻറ്റ് എനിവേ വി ഹാവ് ടു ഗിവ്. ഇപ്പോൾ വി കെ ആംബ്യൂട്ടി വിൽ ഗെറ്റ് 60-70% ഡിസബിലിറ്റി. പക്ഷേ കാല് ഇല്ലല്ലോ സാർ. അപ്പോൾ ആള് പ്രോസസ്സസ് വെച്ച് നടക്കുന്നതും നടക്കാത്തതും എനിവേ ഈസ് വി കെ ആംബ്യൂട്ടി.
We are assessing the impairment only. We are not assessing the disability.
ചിലതിന് സാർ പക്ഷെ നമ്മൾ അപ്പർ ലിംബ് ലോവർ ലിംബ് ആകുമ്പോൾ കൂടുതലും അതിലൊരു ഫങ്ഷണൽ കംപ്ലൈൻറ്റ് നോക്കണം. ചില കാര്യങ്ങൾക്ക് നമുക്കിപ്പോൾ ചിലതിൽ, പക്ഷേ വെൻ കമ്പയർഡ് ടു മെക്ബ്രൈഡ് സ്കെയിൽ ഇറ്റ് ഈസ് മോർ ഗുഡ് സാർ. കാരണം എന്ന് വെച്ചാൽ ഇവിടെ നമ്മൾ ഒത്തിരി ഫങ്ഷണൽ എംപ്ലോയ്മെൻറ്റും കൂടെ നോക്കുന്നുണ്ട്. സാർ പറഞ്ഞ പോലെ ഈ ചില കാര്യത്തിൽ പറ്റുന്നില്ല, പക്ഷെ നമ്മൾ അപ്പർ ലിംബ് ലോവർ ലിംബിൻ്റെ അസസ്മെൻ്റ് ആകുമ്പോൾ കൂടുതലും ഫങ്ഷനിലോട്ട് വരുന്നുണ്ട്. സോ വെൻ കമ്പയർഡ് ടു മെക്ബ്രൈഡ് ഇറ്റ് ഈസ് ഗുഡ്. Anyway, we have to modify, sir. In future.
What are the drawbacks in the proper scale? Sir, one of the drawbacks.
Yeah. In future, Charvagan like physiatrists can improve the scale.
One more thing regarding Zachariah's sentence. Short is the funnel through which all the forces are diverted. It's a very, very good sentence, and that is the truth about it. It is a funnel through which all the forces are acting. So that means all others are important. It is a funnel. It is most important because without that funnel we can't act. And another thing is it's the most mobile joint.
So if there are no more questions, we will wind up the session. Thank you all the speakers.
Can I just add one small point? That is, the quick dash actually is a very good functional assessment scale for before and after your treatment protocols. It's not too difficult. It's only 11 items. And Dr. Divya has pieces, she did it using Quick Dash. which opening jar, touching your back, these are all simple functional issues that we face in our daily lives.
Okay, we will wind up this session. Thank you very much. Thank you all.
May I now request Dr. Surendran sir to kindly present a memento to Vinita Varghese. I now request Dr. Sindhu ma'am to kindly present a memento to Dr. Shahzad sir. May I now request Dr. Sonu Mohan to present a memento to Dr. George Zagria. May I now request Surendran sir to kindly present a memento to Dr. P. Selvan. May I now request Dr. Bindu GS to kindly present a memento as a token of our gratitude to the chairs of our session.
Okay, ready, sir? Ready? Ready? Okay, ready? Okay, ready, sir? Thank you.